Welcome. We are here for ecancertv at the Hematology Debate 2015 in Barcelona. And it is my pleasure to introduce four prestigious colleagues that are going to share with you the most relevant findings that we have been discussing over these 2 days on lymphoma, including mantle cell lymphoma, CLL, and multiple myeloma. Please, Professor Tim Illidge, would you mind just to start with the lymphoma?
Thank you. Our workshop has been about diffuse large B-cell lymphoma, and we are edging forward in the treatment of large B-cell lymphoma to the next big breakthrough after the addition of rituximab to CHOP chemotherapy. What we've looked at is the response-adjusted therapy, and the two recent trials, both from the German and the Canadian groups, have demonstrated that PET is extremely good at predicting outcome. But we cannot switch therapy according to the PET response. We've also looked at a range of different new drugs, and the phase 2 studies are provocative and suggest that, that we may, in the next few years, see improvements of outcome with a more personalised approach towards the treatment of large B-cell lymphoma. Particularly the exciting candidates are the ongoing trial from the NCRI SAC group with bortezomib, with ibrutinib, and also with lenalidomide, the so-called R-squared therapy. And finally, the data that emerged this year with the use of radiotherapy in the treatment of bulk disease is also really rather provocative, and suggests that radiotherapy for some patients with diffuse large B-cell lymphoma is back in the game, suggesting that radiotherapy should be given to patients that have bulky disease around 7.5 centimeters and greater. What we don't know, and a source of ongoing investigation, will be to see whether radiotherapy provides the same benefit for those patients that have bulk disease, where the bulk goes and they become PET negative. So that remains the basis of an ongoing trial that we will do to randomize patients who are PET negative at the end of treatment to see whether they still derive the same benefit for radiotherapy to their bulk disease.
Okay, thanks very much for this excellent summary. Now, Prof Vitolo from Turin, Italy, mantle cell lymphoma.
Mantle cell lymphoma is a rare disease, but it's a challenge disease because, of course, the prognosis of this patient so far is not as good as another type of lymphoma. We have a very good news for the patient now that we have a variety of novel drugs that are very effective in mantle cell lymphoma. In the workshop and the plenary session that we had yesterday, we discussed some new evidence in the treatment of mantle cell lymphoma. First, for the young patient, the issue of the efficacy of rituximab maintenance after autologous stem cell transplants that have been recently demonstrated by the French group. There is an advantage to give rituximab maintenance even after autologous stem cell transplant in order to reduce the relapse rate. This is a safe treatment without any big complication. But the second point that we discussed is the possibility, at least for a subgroup of patients in mantle cell lymphoma, that we can give now a chemotherapy-free regimens with association of different drugs. There are interesting data with R-square regimens, that means rituximab plus lenalidomide, that was presented at ASH, and with this simple regimen, the overall response rate is about more than 80% with prolonged progression-free survival. Also, in the relapse setting, we discussed the use of different drugs like BTK inhibitors, like ibrutinib, that we already know the efficacy in mantle cell lymphoma. And the big point for maybe the first one is that ibrutinib can be safely combined with other drugs like rituximab. Dr. Wang at ASH presented the combination for the first time with rituximab. This seems to improve the efficacy of ibrutinib when compared with the ibrutinib single agent. It's not a randomized study, but just a phase 2 study. Also was presented the lenalidomide in single agents that was more effective than any single agent chemotherapy in a randomized fashion. The key point now is just to find out what is the best patient for each type of novel drug. I mean, we may have patients that be more sensitive to ibrutinib, another one more sensitive to lenalidomide. There are some ongoing studies based on molecular studies, on molecular findings. We try to find out which is the best drug for each patient. There are some preliminary data that suggest, for instance, that some mutational pathway could be could lead to a resistance to ibrutinib or to other type of drugs. So this probably is our goal in the future, just to find out who are the resistant patient to the novel drug.
Thank you very much indeed. And now CLL, Francesc Bosch from Barcelona, where we are in Spain, please.
Thank you, Jesus. So we are in an interesting and new era in CLL. In this era, we are covering the gap between biology insights and the therapy. And in this new field and new era, we have two big players, which are ibrutinib and idelalisib. So these new players are covering an unmet need, like high-risk CLL, like treatment of relapsed patients. So with these new drugs, we are able to treat and obtain a high response rates in these patients with no effective therapies so far. So in this new era, we have new data that has been presented in the last meetings, data that are consolidating the concept of the activity of these drugs, even alone or in combination with monoclonal antibodies. So this is an exciting time for CLL, very exciting, because we are challenging the way we're looking at this disease. So we are challenging the concept of response, because with these new drugs, very effective drugs, patients are controlling the disease, but they don't have a full, complete response. And we are challenging the possibility of transplant in those patients. That was an alternative for therapy. And now using ibrutinib or idelalisib, probably we don't need to do allogeneic transplant anymore.
Thank you very much. And now it is my pleasure just to close this session by discussing multiple myeloma. I think there are emerging data about the possibility of treating the elderly patients and the possibility of using together two standards of care, bortezomib, melphalan, and prednisone with lenalidomide, either in a sequential or in an alternative way. And the Spanish group has shown that with this double scheme, you can reach approximately 3-year progression-free survival, particularly in patients less than 75 years of age. Then I think this is good news. Regarding the transplant candidate patients, the debate is early versus late transplant. Ongoing studies, but at the last meeting, preliminary data was presented by the Italian group showing that early transplant is apparently superior to a delayed transplant, mainly because some of the patients that postponed the transplant for the time of relapse are not able to receive such a transplant. Also, there is important debate about the duration of maintenance. Maintenance with lenalidomide or bortezomib, or both together, or the new drugs, is showing benefit, but we don't know for how long and whether or not this should be offered also to patients that are CR or minimal residual disease negative. Regarding the relapsed patients, I think the most attractive information now is coming from the new monoclonal antibodies, particularly the CD38 monoclonal antibodies that has shown efficacy as single agent and even higher efficacy in combination. In fact, they are being also being tested in the newly diagnosed patient. And finally, it was presented at the last meeting and has been recently published in Blood, also in the relapse setting, a large randomized trial comparing one of the standard of care, lenalidomide dex, versus the same plus carfilzomib, and the triplet in the relapse setting, so with impressive result with benefit in PFS and overall survival. Then I think it's a continuous improvement for myeloma patients, and I think this is a very good news for all of us. And it is now my time just to close this session by thanking all of you for joining us. Thank you very much.
Thank you.
Thank you.